Okay. Hello, everybody. We're happy to start with our webinar about facial reanimation when you can't smile after neurosurgery. We have quite a few cases loaded. We will start by introductory lectures, roughly about 40 minutes, and this will be followed by cases, roughly about 50 minutes. So we have an allotted time of 5 minutes per case, which includes discussion, and I ask everybody in the faculty and in the audience to ask questions regarding the cases. So it is my pleasure to ask for the first presentation by my co-moderator, Kari Flugleholm. He will give you an anatomical overview. Kari.
Can you see my screen now?
We see you.
Not yet.
Okay, so we'll share the screen now.
Yes.
Do you see the screen?
Yes.
Okay, so hello everybody. Welcome to this webinar, and I'm just going to give you a short update on the anatomy of the facial nerve, just to set the anatomy side of things. When I deal with the facial nerve, I always remember what Professor Hugo Fisch said to his fellow Michael Gleason in Zurich in 1985. He said, just a few more moments of your time may save a lifetime of misery for your patient. So try and remember that. Now, looking at the anatomy of the facial nerve, it seems pretty simple. It comes out at the stylomastoid foramen, and then it branches out to the muscles of the face. But is it really that simple? Not for neurosurgeons, I'm afraid. If you look at the anatomy of the facial nerve coming from the brainstem and out, it's a much more complicated thing to look at. And I'm not going to go through this slide, but rather doing it in a more schematic fashion, looking at first the brainstem. And in the brainstem, we have the facial motor nucleus, and from that, the fibers then loop around the nucleus of the sixth nerve, and then it comes into the brainstem again. That is a proper function of the facial nerve. That means the motor function. And looking at that, it's a facial expression, as you know. Many ways you can express with your face, but you move it also when you drink and also when you eat. Indeed, you also use it when you protect your ears against loud noises, and therefore, if you do not have stapedius nerve, you will have hyperacusis. Looking at the other contributions to the facial nerve, which is through the intermedius nerve, the first contribution is from the solitary nucleus, and that is about tasting. So it's the anterior 2/3 of the tongue, and not to forget the palate. Looking at the superior salivatory nucleus, that controls the tears and also saliva from two of the glands, not the parotid gland, that comes from the glossopharyngeal nerve. And then also the nasal glands, and patients will complain about having a dry nose on the side of the palsy. The spinal nucleus of 5 will contribute with the sensory function of the outer ear canal, and therefore, if you have intermedius neuralgia, you will have ear pain or otalgia, and that will also be quite a rare situation, but you should also remember that this is part of the facial nerve. It's not only motor, it's also sensory. So looking at the whole schematic representation of the anatomy here, there are two important things I want to show you. It's the transition zone between the central myelin and the peripheral myelin that means between oligodendrocytes and Schwann cells. It's called the Obersteiner-Redlich zone. And for the facial nerve proper, it's 2 millimeters from the brainstem, whereas from the intermedius nerve that joins the facial nerve at the pores edge, then it is only 0.3 millimeters. And it means that if you make a lesion to the facial nerve or the intermedius nerve in the cistern, you will be able to have regeneration. Whereas if you have a lesion that's at the colliculus in the floor of the fourth ventricle, you will have no regeneration whatsoever, no matter how long you wait. So if you then look at when the intermedius nerve joins the facial nerve and becomes one big facial nerve, it's in the petrous bone, and then you have the greater procersal nerve, you have the stapedius nerve, the chorda tympani, and the sensory auricular branch that all leaves in the temporal bone. And after the stylomastoid foramen, of course, you have only the motor branches. So that is a quick overview of the anatomy of the facial nerve from the brainstem and out to the face. So when you have lesions in neurosurgery, it's most often either in the cistern when you operate for acoustic neuromas or CPA lesions, or it's in the petrous bone when you do various skull base approaches. So that's where you have the lesions, and it will depend where the lesion is, how many of these deficits you will have. So looking at the anatomy of the facial nerve outside the stylomastoid foramen, of course, there are some important structures, as you know, the parotid gland, because you're going to dissect the parotid gland when you do nerve transfers. You should also know the masseter muscles. It's where you get the nerve supply to one of the nerve transfers. You can look at the temporalis muscle that you can use for lengthening myoplasty, and the greater auricular nerve you can use as a nerve graft if you don't want to use a sural nerve. So the skull base pathology with a significant risk of facial nerve damage during surgery, it would be large CPA lesions, it's facial neuromas, it's vascular lesions, hemifacial spasm, and there are many more. And looking at the facial nerve anatomy, you also always have to remember that the anatomy differs with the pathology. And here you see the facial nerve over a meningioma, and you can see that it is spread out like a fan, and you can actually only see the nerve with a stimulator. You cannot see where the nerve is unless you have the stimulation with you. So the last thing I want to stress in this presentation about the anatomy is the cortical representation of the facial movements, and that is because that is here, you know, the homunculus, and the face is here, the tongue is here. So if you do a 12-7 nerve transfer, then there will be far between the two cortical representations, whereas if you do a 5-7, you will actually be closer, and that has a lot to mean or say when you talk about plasticity in the cortex and how the patients can actually train their facial movements after repair. So that kind of anatomy you also need to know. And that is actually what I had to say to start with. So thank you.
So thanks, Kurt, very much. So do we already have a question in the audience? We don't, and I just ask you to also use Q&A if you have questions. So is there anything from the panelists? If not, I would suggest that that I just go ahead with the next presentation. So, can you see me?
No, not yet. Please try again, Thomas.
Okay.
Okay. Yes. Now it's okay.
All right. So we're gonna shortly talk about the possibilities we have. I'm sorry, doesn't move forward. I'm blocked here. Now it works. So if we talk about therapy, we want to know about, as Corey alluded to already, lesion mechanisms and types, meaning what is the reason and where is your lesion. You need to know about non-surgical treatment. You need to know about surgical options and what you could do, and especially when you do one. So the principal question, why is regeneration so difficult, and why is it frequently dissatisfactory? And basically, Corey already gave the answer. Just look at all these tiny muscles, and all these tiny muscles only work in coordination. And it's that is why it's so difficult to get satisfying regeneration. It's would be a lot easier if you'd have bulky and not so fine, not such a fine musculature. So what are the elements of reanimation of mechanical function? So one important point is exercise, and we hear a whole talk about that. And then we have primary or secondary surgical measures, and we also could divide the surgical measures in between static or dynamic. And the important questions that you want to ask yourself for before you begin your treatment or you make a choice is, do you talk about a complete lesion or an incomplete lesion? Something that is frequently forgotten by neurosurgeons is very simple to answer. Is the eye protected to not risk an ulceration of your cornea? So you should have a picture of how long you wait for spontaneous recovery, and of course, what kind of surgery and when. Do you go for a nerve procedure, or do you go for a substitute procedure? And do you use static or dynamic substitute procedures, or do you combine? And all of this will be answered in the exemplary cases that we also will see. So I would recommend that you await spontaneous recovery if you know that your nerve is not transected and you still had good answering potentials during your primary surgery, for example, your vestibular schwannoma resection. And you should find out if there is a realistic chance for spontaneous recovery. So is there functional improvement visible or measurable? And actually, you should test for both. So one thing is EMG of all the major muscles, and the next is video and photographic control. So principally, I would say, as for other nerve reconstruction, I would not wait a lot longer as preferably 3 months until I make a decision. And of course, this can be discussed. So once again, we have primary surgery, we have secondary surgery. So the repair of the facial nerve per se would be, per definition, a nerve reconstruction. That should be pretty immediate or fast. And that is something else that is frequently not even thought about, that you could do it on the spot. Sometimes you could repair and reconstruct the facial nerve intradurally, or at least 2 or 3 days later. And then we have the choice of reconstruction of nerve function via nerve transfer. And then we have all the secondary measures, which we will hear about later on. So if we talk about static procedures to actually lift the denervated structures, you will later on hear about facelift, suspension, tarsorrhaphy, and cantopexy. So this is just to already have it in mind. And then we have dynamic procedures, meaning muscles that will contract and give you an active movement. So we have very old procedures, for example, taking the temporal muscle. There's a so-called Gillies suspension, there's a McLaughlin suspension. You could take the masseter muscle, you could combine, and there is the option of using a free functioning muscle transfer. So with that, we also have a lot of options, how you coapt the nerve, and of course you also have to connect the vasculature. And for Reanimation, you have the choice of different axon donors. One could be the contralateral facial nerve that is transferred to the nasolabial fold. The other option could be the ipsilateral masseter nerve that you just heard about from Corey, or upper parts of the ipsilateral seventh nerve, or this is actually wrong, the hypoglossal or other motor nerves. Another way to look at the damage is if you divide it by facial expressions. So you, for example, could divide it into 4 functional units: the brow complex, the periorbital complex, the midface complex, and the perioral complex. And with an optimal solution, and you do not always have that, of course, you want to have improvement for all the 4 complexes. So in an acute or even subacute lesion, I think we should consider direct graft reconstruction at the CPA with a sensory nerve. So you already heard that quite local is the greater auricular nerve. There could also be the transverse cervices or the sural nerve from the leg. And then we have quite a lot of choices for nerve transfers. All of these have advantages and disadvantages, and I'm sure we will hear about that later on. So a very old and often used transfer is the hypoglossal transfer. Then you have the nervus mesentericus transfer, the temporalis branch transfer, and also an accessory nerve branch. And then you have a variety of crossface techniques. This is just to show you that all of this, or most of this, is not new at all. This is the original paper from Norman Dodd from '58, where he actually reconstructed the facial nerve by an extrapetrous nerve graft. And this is 10 years later, after an injury sustained in 1945. So you see the patient at rest, smiling slightly. And of course, this does not function that nice when he tries to draw the mouth to the right. This is an example of instant graft reconstruction, intracranial, after a large tumor was resected, and it was already clear that within the CPA, the nerve is completely transected and gone with the tumor. So in principle, you have a direct graft repair. And that is the patient 5 months. So this is 5 months after that graft reconstruction you just saw. So this is not the end result. And you, of course, you see some improvement here in these complexes, and no renovation yet at the forehead. So the hypoglossal nerve is a very old player. So this is one of the first transfers transcribed by Corti in 1903. And right now, we actually see a revival, because the first results were quite bad, and most likely because the whole part of the hypoglossal was taken. So this is probably a solution nobody would use anymore. And nowadays there is a plethora of different solutions where actually just a split part of the hypoglossal nerve is used in variations, end to end, side to end. Another so-called descending branch of the hypoglossal is used. I won't go into detail. I just want to draw your attention to that very nice paper of Mariano Sokolowski from 2016, where he actually compared some of the hemihypoglossal to facial transfers to masseter to facial nerve transfer, and actually the direct hemi 12 to 7 worked best, and the one with an interposed graft was actually the worst. So Kåre already showed you an anatomical picture, and those are the regions of interest, and those are the other branches we could use as axon donors. The mesenteric nerve, once again, and the deep temporal branches, because there are several temporal branches, also an anterior branch, and here the hypoglossal nerve. Another interesting paper from Mark Mahan, where he used a deep temporal nerve transfer. You see what can be achieved with that approach. There are anatomical papers that nicely depict the relevant anatomy. Sometimes it might not be that easy to find the mesenteric branch. And I think we have also cases about that. This has nothing to do with reanimation, but we have some static procedures, and one that you probably know about is the implantation of a piece of metal. It used to be gold, nowadays it's more or less platinum. And as always, the advantages and disadvantages. I won't go into detail about that. This is anyway by Kartik, and Kartik will give you a talk about that. So in the end, we also have to draw the attention to do we have an acute or subacute lesion or a chronic lesion? And maybe for a very old facial nerve deficit, we need another solution. And one of these solutions might be an FFMT, a free functional muscle transfer. And this is how the muscle can look. This is taken from an open access atlas by Gregory Borchell. This is how you can use the muscle. This I will leave out. This is with courtesy of Kartik. And as always, there are advantages and disadvantages of any procedure. And this is from the very recent literature, just to show you that actually everything, with every technique, everything is under discussion. This is an example of a free functioning muscle transfer. And so the question would be, which kind of donor nerve do you take? Do you do the procedure single versus stage? Do you use a dual innervation? Do you use multi-vector flaps? And this is just the technical parts. And there are much more aspects of facial nerve reanimation. We have the subject and topic of misrouted sprouting. We have sometimes the crocodile tear phenomenon. When it comes to treatment, it's very important to use the right treatment, and we have the following talk about that. And it's very important to look for adequate time periods. So in summary, I think you should decide within 3 months about the potential for spontaneous regeneration. If there is no transaction, if there's a transaction, there's no need to wait. And then you have the choice between nerve reconstruction, new and old nerve transfers, multiple donors. There's a trend to use donors in combination. You have cross-phase techniques, and you have a whole lot of substitute procedures, including free functioning muscle transfer. And most important of all, and sometimes that is forgotten, you need to exercise a lot, and that in a proper way. So thank you very much for listening. So we'll stop with that.
Okay. Before Mette Wolters start her presentation, I just want to introduce her. Mette is one of the consultants here at the Rigshospitalet in Copenhagen in plastic and reconstructive surgery. And Mette is actually the one and only facial reanimation surgeon in Denmark. So every case in Denmark will be referred to us. Mette and I operate together when we do various procedures, but a lot of the things Mette, of course, does on her own and with her colleagues. So please, Mette, go ahead with your presentation. Yes. Okay.
Here we are. We're still looking for the presentation.
Just a second.
Just. It has stopped sharing the screen and videos. Just.
We're just trying again. Let me take it from here. Okay. So that's it.
Here we are.
Mette, I'm afraid you need to unshare it and share it again, but please have your PowerPoint ready, because right now we see the folder. We don't see the presentation yet. So you need to unshare it.
Yes.
Have your presentation open and then share the screen again.
New share.
The presentation open and then share after that. So stop share.
Because Zoom cannot switch the screens, so that's the issue.
Okay, and then share again.
Mm-hmm.
Not possible. Bare gå ind på Zoom. Bare gå ind på Zoom dernede. Og så står der også at share. Okay.
It is already open. I don't know why it is teasing us.
Bare klik på den der. Can you see it now?
Yes, it's perfect.
Okay, it is
so
perfect.
We'll just start.
Thank you very much.
That's great, fantastic.
Okay.
Thank you. Thank you very much for the invitation. I'm afraid some of what I had planned to say has already been said, so I'll be very brief. When looking at indications for treatment of facial paralysis, we start with an assessment, and as has been previously noted, the nerve continuity is of importance, and one of the things that we consider, as well as the duration of the paralysis, the likelihood of recovery, but also patient comorbidities, life expectancy, age of the patient, and all these things are intimately linked with what individually tailored treatment we will be able to plan. So the principles will be that we try to individually tailor the treatments, and it will usually consist of both the static and dynamic procedures, as Thomas also just mentioned. If we try to manage the upper and the lower face separately in order to avoid mass movement, and if you have a choice, reanimation should obviously be achieved as soon as possible in order to maintain the functional motor units, as was also previously mentioned. The facial mimical muscles are very slight, and they don't tolerate denervation very well. So as soon as you can. Also already mentioned, if you have a section nerve, you should repair it as soon as possible, preferably at once. Because direct suture, when possible, is the single best predictor of positive outcome, and this is really something to stress. I guess we have a bit more patients up north. If we have a patient with an intact nerve with a realistic chance of recovery, we can monitor the recovery potential for upwards a year, although if nothing has happened, if you have a complete paralysis and nothing happens in 6 months, we will also intervene. We talked about the direct suture or the acute nerve injuries, and in the intermediary group is where the nerve is obviously missing, but the muscles are still in a reversible, in a state of where the damage can be reversed. I just wanted to remind you of these things. You have a normal muscle here, and the effect of denervation after less than a year, and what happens in this area between about a year and more than a year. You have irreversible damage here. There's no hope that this is going to work, even if you manage some kind of reanimation. So the choice of donor nerve has also already been covered. Our favorite is the mesenteric nerve because it is located, because of where it is located, and also because of the large number of axons. It has probably 1,300 or 1,500 axons, depending on who you ask. And formerly, there are a lot of alternatives. The accessory nerve has, again, also in plastic surgical units become increasingly popular in particularly maybe in Asia, I think. We prefer the mesenteric nerve here. And if you look at the donor side morbidity, you can find a reduction in morphometry, but there's no reduction of function when you take this away. So it is doable to use it as a donor nerve. A colleague, Shai Rosen, has these great pictures. Some will argue to use only a partial. This is supposed to be the mesenteric nerve here, coming up from the deep side of the mesenteric area and connected to the buccal branches of the facial nerve. We more often actually prefer to do the whole nerve trunk. In order to do that, I think this picture is a bit optimistic. It is usually necessary to sacrifice the branches to the neck in order to make a direct tension-free suture in the face. This is one example of an acoustic neuroma patient after surgery, about 9 months out after surgery. And this is she after such a procedure with the whole facial nerve, the whole facial nerve trunk anastomosed to the mesenteric nerve. And so far we have not really had any patients with so much mass function that it has become a problem, but we are obviously ready to take out some of the nerve branches around the eye, or to depress that either with Botox or surgery, but it has so far has not been necessary for any of these nerve transfer patients. If we leave the intermediary group and go to long-standing facial paralysis, where the muscles are no longer functioning and no longer able to be revived with reanimation, we have started using a different method of the temporal muscle reanimations. We've already heard about the Gillies and the McLaughlin methods that were popular. The problem with those are they give a lot of bulk over the zygomatic arch, whereas this technique that was developed by Professor Labbé in Caen in France around the turn of the century does not do these things and gives actually a good single stage operation that we are happy to use with elderly patients in particular. What you do is you take off the insertion or the insertion of the temporal muscle from both the origin on the skull and from the coronoid process, and then you can mobilize it anteriorly on the neurovascular pedicle that comes from the central area here, and you can reattach it to the nasolabial fold. And after it has settled in, after 3 weeks, they can start training. And now it was, moving forward here. This is one patient, which is seen here preoperatively, and with a bit of an excess smile after 3 months, which then settles into something quite useful and worthwhile after 6 months. If the regional muscle transfers are no longer possible, then you can use muscle transplants. The best results is seen in children or young adults where they have shorter regeneration distance and better cortical plasticity. There's definitely controversy about the upper age limits of some of the, at least the 2-stage procedures. And for these, the reported results are good to excellent in maybe 50%. So it means that there are many things that also has previously been mentioned that can be suboptimal. For the classic 2-stage procedure, you have the facial nerve of the opposite side as a donor, and the reanimation will include an unconscious smile when it works. It's a long process though, and it can be difficult to achieve. An alternative is the 1-stage where you take the muscle transfer to the masseter nerve, which is faster and usually stronger, again, because it's a strong donor nerve. And it will require some more re-education along with the other chewing muscle reanimations. This is the gracilis muscle in situ on the leg with the anterior branch of the obturator nerve that is long and nice and usable, and the vasculus pedicle. And this is an old picture. We don't insert it like this anymore, but this is the vascular pedicle again, and where it is used. We prefer the gracilis as it was written because it is small and has a good contraction, but many other muscles are possible to use. These are just examples because I wanted to show that in the dynamic procedure here preoperatively and here just after the 2nd-stage surgery, you get an immediate lift from of the angle of the mouth from the passive lift of the muscle. And then you get movement later on. And here's one with a single-stage Mebius patient with only lower branch facial nerve working, and she has a normal smile that she uses on a daily basis, and with the maximal smile you really can see how strong the contraction is. And yes, it's a teamwork. That was it for me. Thank you.
Excellent. Thank you. Thank you very much. So I think we just go on with the blocks because I assume most of the questions will be together with the cases. So it is my pleasure to introduce to you our speech and language therapist from Klagenfurt, Christina Repic, which will tell you about ways of non-surgical treatment.
So good evening. My name is Christina Repic and I'm a speech and language therapist. And today I want to talk about facial palsy and speech and language therapy. As you know, facial palsy is one of the most common peripheral nerve diseases that leads to a number of physical and emotional issues and subsequently to daily impairment. As a speech and language therapist, I've often had the feeling that this topic has been neglected in healthcare. Hardly anyone has dealt about, for example, patients with chronic symptoms of facial palsy and their impact of daily life. It is usually assumed that someone else will take care about the problem. But as an expert, I think it is our work to accompany patients on their way. This was the reason why I founded the Facial Palsy Ambulance in 2016, including the Department of Plastic Surgery and Neurosurgery in our clinic. Within the last years, the overall mindset on facial palsy has started to change. Now we know that multidisciplinary treatment brings along several advantages. This approach makes it possible to reduce the burden of those affected and increases the quality of life. This can be represented by different specific or general grading scales like FDI or FACE. To achieve optimal results, it is essential for patients to be treated by a physical therapist or speech and language therapist. The ultimate goal is to improve physical issues, this should be should happen through neuromuscular retraining. And to do so, we use the skills of motor learning processes. But what is the task of a speech and language therapist? In all cases, we typically start with counseling sessions where we explain the patients how to deal with their physical issues like eating problems or drinking problems and the problem of eye closure. We also educate the patient about the task and the physical functions of the facial nerve. We make sure that the patient understands the connection between the facial nerve and the functional connections of the nerve and the issues he's experiencing due to the facial palsy. This basic understanding is the precondition for the therapy because it helps the patient to understand the purpose of our exercises. And another important part of the speech and language therapy is the therapy. Through the therapy, we want to improve following issues, like the facial expressions. We want to improve eyelid closure, eating and drinking. We also want to reduce facial pain and have an impact on spasms or synkinesias. Based on our practical work and scientific data, we know that the average interval of the first and the last visitation in the clinic is about 1 year or 1 year and 9 months. So before I want to talk about the treatment strategies, I want to talk about the optimal moment for speech and language therapy. Unfortunately, I cannot give you a straight answer to this because you cannot generalize it. Overall, it depends on the type and the cause of facial palsy, and it always has to be decided on a case-by-case basis. But all in all, I recommend that speech and language therapy should start, for example, at an idiopathic facial palsy or by a viral or inflammatory cause of facial palsy 2 or 3 weeks after the onset. and after the drug-based therapy, because we don't want to sprinkle any inflammatory diseases over all the structured tissues. If a patient has a iatrogenic facial palsy, you can start immediately after the damage, and you can also plan functional electric stimulation if there is no malignity. If you want to know more about facial palsy, I will recommend you the book Functional Electric Stimulation in Neurorehabilitation, which will be available soon. And there I wrote an article about functional electric stimulation and facial palsy. If a patient has a chronic facial palsy, you can also start immediately and try to make functional electric stimulation, because we know that this can have an impact on the tissue. And if there was a reanimation operation, speech and language therapy should also start 1 week after the sutura removal. And you can also plan functional electric stimulation in some cases after 4 or 6 weeks after the operation. And now I want to talk about the therapeutic elements of the speech and language therapy. Usually we talk about 4 conscious phases of treatment. The first phase is the initiation strategy. Here we focus on the improvement of self-awareness, and we guide the patient how to perform the exercises. To improve or maintain the muscle strength, we also use functional electric stimulation. And if the patient is able to activate the muscle, we go ahead into the next phase, the facilitation. Here we use the onset of the muscle activity and support it through different tone activating measures like BNF or FES. In the next phase, we want to control the motion, and therefore we use biofeedback skills like EMG or mirror therapy to gain the control of the facial movements. And another phase that is happening parallel to all the others is the implementation of relaxing techniques. These are mainly used to decrease the tonus of tight muscles, and especially if a patient suffers from synkinesias or hemifacial spasms. So based on motor learning processes, we aim to regain motoric skills to improve the functional and physical issues. To achieve this, we focus our work around following points. We want long-term improvement of motoric conditions. We want control and we want the control of the facial movements, and we also try to correct facial movements if it is wrong. We want to improve the facial symmetry, and we try to reduce pain, discomfort, and synkinesias. And we work on the self-awareness of patients. We try to improve the strength and endurance of muscles, and we want to avoid incorrect sprouting through targeted practice. We try to offer techniques to relax the muscles, and we improve functions of chewing, swallowing, and drinking. So overall, I can say that the impact of a multidisciplinary treatment on facial palsy has proven positive effects on the quality of life. So it is essential that the patients are treated by speech and language therapists besides the medical therapy to improve physical issues, emotional issues, so we can have an effect on everyday's life and the quality of life. Thank you for listening.
So thank you very much, Christina. think we now have a pretty good base for the following cases. So on the Q&A, there has been one question that has been answered. There's nothing right now. So I think we can actually start with the first case, and the first case will be by Cora.
Okay, so we will go ahead. I will just share my screen with you. Can you see my screen?
Yes.
Good. So this is the first case, and this is a lady. She's 52, and she has this rather small vestibular schwannoma. And what you can see here is that it has widened the meatus, and there's an irregular shape at the porous edge. And what unfortunately happened many years ago was, of course, we don't do this today, was that we lost the facial nerve at the porous edge, meaning that we had a kind of a transection. Of course, the facial nerve was very widened at this stage here where it happened. And now we had the complete tumor removal, but we ended up with a facial nerve that was not stimulating and not in continuity. So the question is what to do in this situation. So I think we should ask everybody what should be done here.
So anybody in the audience who has the answer, you can write it on the Q&A. No answer so far. So I think, Corey, you go ahead.
Okay, we go ahead. In this situation, there's no doubt that if you have the skills to operate on a vestibular schwannoma, you also have the skills to deal with the situation in the same operation, as you should always do that. You can, in this situation, you can try out if you can do a direct anastomosis, and that is possible, especially if it's a large tumor. Then you will often have the tumor stretching the nerve in a way that you can actually still get the nerve to reach, and you can do a direct cooptation. Otherwise, you will have to take a graft, as we've heard before. In this case, fortunately, the nerve could reach, and you can here see the anastomosis here, and there is no sutures here. This is just locked with fibrin glue, and because there's no stretch forces in intracranially, you can leave it like that. Just build it up on some spondystone, and it will stay nice and safe there. What the result you will get, you can see here. The lady has a facial palsy, and I'm sure you will guess that it is on either side. I don't know if you can see which side it is. I perhaps would guess on this side, but then I would be wrong because it was actually on the other side. You can see she has achieved a nice nasolabial fold, and she has a lot of tone in this side of the face, and this is actually her problem. And we've had to modulate this a lot with Botox because she had a lot of synkinesis. But essentially, she has a function House-Brackmann tree, which is what we almost always achieve, whether it's a direct suture or whether it is a direct graft. So this is how she looks. And just remember, if you have patients with synkinesis and too much tone, that can be to some degree fixed with Botox treatment. So that was the first case. So I will now stop sharing my screen and then we will share Mette's presentation.
Just there's one question in between.
That's one question.
So, yeah, there's a question. Well, it's not related to your case, but I think we might still answer it in between.
Yes.
Because there are not that many questions. So this is from Giovanni Girolotta. So this is to the plenary, to the plenum. Would you offer electric stimulation to a young patient of 18 years with chronic 1 year of Bell's paralysis, or directly propose some dynamic surgery? So if the others unmute in the plenum, do you want to quickly respond? Kartik?
Yes and no, because first of all, I would like to wait for 3 months for spontaneous regeneration and see if there is any, because there are two things to it. The mimic musculature is a little different from the massive muscles we have on the extremities. Mimic musculatures are very fine muscles. So if you apply the same principles of electric stimulation as you apply for the extremities, you might even burn out the muscles or the synapses. So I would rather wait for some kind of regeneration, some kind of twitching to happen, and then think about applying electric stimulation in a very, very careful way. Not
even
like the way we use it for.
Even if it has been 1 year?
1 year doesn't help at all. Forget it.
Because that was the question. That was 1 year of Bell's palsy.
Well, no, it doesn't help. No. I won't. No, it doesn't help. It's atrophy. I mean, the basic principle of electric stimulation is to stimulate the neuromuscular junctions within a muscle. And if the neuromuscular junctions are gone, so there is no point in stimulating them. It's like stimulating a piece of cloth.
Christina, do you want to add something? Would you?
Yes.
Would you still
I would try it because there are scientific data that say that the muscles can increase, and so maybe the symmetric would be a little bit better. So I would try it.
Even after a year?
Yes.
Because you want to try because you think it might not be complete, or what would be the rationale?
For example, we had a patient who also had chronic facial palsy, and then we tried to make functional electric stimulation, and after a time he got better, and he also was able to move his facial muscles for a little bit.
Okay. Corey, you want to add something?
I just want to stress something here, and that is that we know that we lose the end plates, and that functional stimulation might actually help that in the early phase, and maybe also later, even at 1 year. But what we also know is that the distal nerve, where the Valerian degeneration takes place, will have lots of Schwann cells and a nice atmosphere for regeneration, with lots of trophic factors and stuff, and that will be lost also. And people seem to forget that this is also a time-limiting process, and that the distal part of the nerve that we will need to use for reinnervation will actually degenerate, and Schwann cells will disappear, and the distal nerve will not be suitable for reinnervation if you wait for example, 2 years. So that is also a limiting factor. It's not only losing the end plates, it's also the distal nerve segment, and that has also been shown very nicely in literature. So that was just one comment to that. So I agree with Kartik that you should not stimulate after a year. Go ahead and do something to help the situation before you lose it.
Okay, shall we go on with Mette's case?
Yes. Can you see the slides now?
Yes.
Very good. Så, se det der, nu kommer forsvandt den.
Just a second. We'll just see if we can get this one. Yeah. 2 seconds. I think we have it.
Here we are. I brought a case with a patient that was referred about a year after operation for a residual acoustic neuroma. He was a 74-year-old male. He tried all sorts of things, lasers and acupuncture and training, self-training, which did not affect anything. So he had a Haus-Brackmann 6 on his left side. Yes, I have his pictures here. And while the participants are maybe thinking about what to do about him, we can just say that you can note here the complete C-shape of the face after chronic facial palsy. He's a very typical case in this respect, and the complete flaccid paralysis on his left side, including eye changes. So I don't know if there's any comments from the audience of if I should just go ahead.
Let me check. We always have questions, and but they are not related so far to the cases. So
I'm just moving on then.
Yeah, just go ahead.
Yes, this is he after a temporalis lengthening myoplasty. So the insertion will be here at the nasolabial fold, which is nicely mirrored to the healthy side. And this is where the pull is. So for a closed mouth smile, the symmetry is actually quite good. You can note here that there's no extra bulk around the zygomatic arch. But when you do, when he shows his teeth, you can see that it does not pull downwards on the mouth, which is how it is. That is just unable to be, you can't change this. And he's later on gone on to do also little things like you were saying, cantopexy and yes, little corrective surgeries around the eyes. And that was it.
Okay, thank you. So I think in the meantime we can answer one of the. Sorry, there's no question to this case. We can try to answer one of the other questions. So they are mixed in between Q&A and chat. Please try to use Q&A. Makes it easier for us for your questions. And maybe in the meantime, Max gets started. So in the chat, we have the question, how do you manage a partial recovery? Example, only orbicular oris and mouth recovery, no upper branches movement or vice versa. 6 months after CPA surgery with anatomically preserved 7th nerve. Continue rehab or surgery? Kartik or Mette or Cora, do you want to reply to that?
So if the lower quadrant is reinnervated and the upper quadrant not, then I would resort to secondary procedures such as suspension, bro suspension, and weighting lid loading procedures. Then going in and and trying to do some kind of experimental reinnervation from the contralateral side, or reinnervating only the upper branches of the facial nerve. That would be my my approach.
So in a nutshell, after 6 months, even if it's partial, you go for surgery.
Yeah, sure.
Okay.
It depends on how severe the
Mette, could we get a reply from your side?
I think that we would probably wait a bit longer and then again tailor and do the same as Kartik said, to do you can do a nerve graft to only the relevant branches, but it's going to take a long time. And if you already have some recovery of movement, I would actually expect some more to arrive.
Would you just wait, or would you also make use of, for example, EMG, or to see something?
Yes, that would be, but I would do sort of conservative measures. So measure the progress and then use the occupational therapist, or as you have a speech therapist, and carry on with the training and try to focus the training. But I would be prepared to wait. If it's only 6 months after and you already have seen good reinnervation to the other half of the face, I would wait for more.
Okay. So we got case number 3, Maximilian Neuwirth.
So can you see the screen?
Yes.
You can see it?
Perfectly well, yes.
Okay, fine. So hi everybody, my name is Max from Austria. I am part of the interdisciplinary facial paralysis team in Klagenfurt in Austria. And I am proud to present the next case. My case is a 24-year-old male patient who visited my outpatient clinic, or our outpatient clinic, 1 year after he had a vestibular schwannoma surgery. During the surgery, the neurosurgeon told me that the schwannoma was so big that they could not save the facial nerve and had to dissect it, and they tried to interpose it with a small nerve graft. Unfortunately, this patient came after 1 year, and the electrophysiological checkups, and also our speech therapist, Kristina Repic, saw not really good signs of regeneration. So we asked ourselves what to do and how we could do something without disturbing a possible effect in the future of this nerve graft. So we thought maybe we will not disturb the nerve on this side and do a free gracilis transfer for the mouth, because this was his biggest issue. So together with the patient and our group, we defined 2 reconstructive targets. The first was the mouth. I think the mouth is always the biggest stigma for all facial paralysis patients, not the physical ability its own to have some oral competence and some speech, but also the emotional fact. It makes this like a important psychological factor, the interact. And the second problem was his eye. He had this leg of thalmus, as you see on the lower picture. So he asked us to also check if we can do something there. So we set up our surgical plan, and we thought we will do a 2-stage facial reanimation. We wanted to do a dynamic smile reanimation in 2 stages. We always do it in 2 stages. Stage 1, classic cross-face nerve grafting from the contralateral side, and stage 2, free functional muscle transfer. We use most of the times the gracilis. The eye closure, we tried some cases, to be honest, with a split gracilis, but in my personal opinion, I have not such a big experience than Mette and you, but the results are quite unpredictable, and I'm quite happy with these platinum white implants on the upper lid for eye closure. So we did in the first stage the classic cross-face nerve grafting. After all these good talks, excellent talks, I think I can skip that. On the right side, you see the patient with the nerve graft already in situ under the facelift incision. And then on the second stage, we used a gracilis graft, which you see here, was already explained by the others, so I skipped this as well. So this is a quite earlier post-op picture. Critically, I have to say, the flap looks quite bulky, I know, and from an aesthetic point of view, I could have done better, I think. The static component, I think it's quite okay. Also, the eye closure is quite okay, and he has good movement of the oral commissure, a really strong movement. Also, the scar, I think it's quite okay, and for me, because there is always the discussion about when use the masseter nerve, one do the contralateral cross-face nerve grafts, and for me, the biggest advantage of the contralateral cross-face nerve grafts is that all the excursion of the mouth is not only you have the physical ability to open the mouth, you have an emotionally linked ability to smile with the other side. And I think this emotionally linked component for me is the biggest advantage of the cross-face technique, although other techniques are also working perfect, and we saw some excellent results. So thanks, that was my first case.
Thank you very much. Any comment from the plenum? In the meantime, I'm trying to check.
I just wanted to tell that this patient, this is not the final result now. So because we are not happy as aesthetic surgeons as well, we are not happy with the bulk, and we will do a small debulking. I think it's always dangerous to debulk these muscles, but I think we could do it a little bit on the origin, because the origin in this case was quite high, I remember, and we will do some smaller facelift. But from a critical point of view, that's a little bit too bulky, I think.
Any more comments? Okay, Kartik?
Yes, if I may comment on the bulk of the muscle, I also had this problem in my early experience. So I tried to split the gracilis to adapt to the face of the patient, and also the second thing is you should remember that the face itself does not have lymph nodes; it has only lymph vessels. So there's going to be considerable lymphedema if you use big incisions. That is why the use of the retractor integrated endoscope, which we had developed several years ago, has enormously helped me in reducing this kind of bulky face after the surgery. So first, decrease the size of the muscle itself, and second, use minimally invasive techniques and a very fine operating technique to decrease any kind of swelling that might also hold for a longer time.
Thank you. You're right.
Okay. Mette is next, case number.
Then can you see the screen?
Yes.
Can you see the screen now? Here we are. So this is a lady, late 50s, with gradual onset of facial palsy over 2 years. When the paralysis was complete, she was then diagnosed with an acoustic neuroma and operated. And during the surgery, the facial nerve could be stimulated but postoperatively, again, the left side was paralyzed. So we have a nerve that has been suffering for more than 2 years. And then because it was possible to stimulate during surgery, she was referred after, I think, 9 months. And so this was what she looked like after 9 months with a complete House-Brackmann 506 facial palsy on the left side. And are we waiting for suggestions to treatment, or we just carry on?
Let me check. Any suggestions? Please feel free to write something or type something in Q&A. Very shy audience. Max, what would be your suggestion?
That is putting him on the spot.
Okay, I think you just
Sorry.
We can carry on.
Max, anything?
Sorry, I have some technical problems.
Now we can hear you.
I can say what we were considering. We thought that if we did a nerve transfer, we would have the option to do this and wait to see if that could have any function. We were a bit in doubt because of this prolonged period of not optimal nerve function, at least, and then 9 months of denervation after the surgery. But we thought that we could probably do a temporalis myoplasty on top if the nerve transfer did not work. So this is how we did this. This is she after 4 months. You can see that she has now a bit of tone in the left side of the face. Did I not mention that we did a nerve transfer from the mesenteric nerve to the facial nerve? That is it. So this is post-op 4 months. And again, at rest here on the left side, and in a small smile and a larger smile at 10 months post-operative. And she gets actually a quite impressive amount of activation of the lower lid, and also a movement upwards of the cheek, which is also a part of the smile. The smile is not only how much does the corner of the mouth move, it is the whole cheek that is part of the smile. So again, when she's showing the teeth, we had to sacrifice the marginal branch in order to make the direct adaptation or the direct tensionless suture, and we did not want to use a graft in this lady because of the long period. We prefer to do the direct suture in any case. And this is then she, unfortunately, very depressed because when she is relaxed, there's no function, and so she needs to use it. She's very, very good at using it, and when she uses it, it looks really fantastic, but she was so upset that she would not get a resting tone. That the pictures shows to me anyway that she was quite unhappy when these photos were taken. But surgically, she has a really, really good result from a nerve transfer, and she has yet to deal with the limitations that follow these things. So that was this case.
Thank you very much. Excellent case, excellent result. But also underlines what Christina said, that there is not only the functional aspect with these patients. I think quite a few of them are quite depressed. Kartik, you wanted to add something.
Yeah, that's thank you very much. That was a very, very good case to underline the psychological issues involved in this kind of treatment as well, because after all, we are treating patients and human beings and not just diseases. This is one of the reasons why frontally I address this issue right away when we are treating patients like this, that they should not, the expectation levels should be not too high, and they should have realistic expectations. This counseling is so very important. Some programs, some units use social psychologists to do this job, just exactly like, when we have an oncology patient, when we have a breast cancer patient, we have teams that address these issues, but we don't have these things for patients who have facial palsy or palsies, other extremity palsies. So this is something which we have to think about within our units to include. It's not only about a surgeon doing his job or a physiotherapist doing his job, but also a psychologist doing his or her job.
Yes, very much so. There's one question in Q&A, and I would ask Max to prepare again his case. So in the meantime, we have the question by Julia Del Moro, and please, this goes to the plenum. When do you think is a correct timing for a nerve graft or masseter facial nerve coaptation in house embragment 6 deficit, but no intraoperative transection in a young patient? 12 months was said that sometimes could be too late because of muscular atrophy. So, Mette, if you want to start.
Yes, I think we tend to start talking to each other around 6 months, and then we look to do surgery no later than 9 months. And if we know that we are in a situation where no regeneration is possible, then we would do it quicker. But with the waiting list and the theater, all these spaces, I think between, I don't know, not much sooner though than 6 months. I don't think that's physically possible for us because of what else we do.
But so you would definitely not go with my previously suggested 3 months, 3 to 6 months.
If I'm absolutely certain, if the damage is at a place where there's no chance of regeneration, then there's not much to wait for. I agree with you there. I'm just a little depressed with our practical situation here with how quick we can see them and get it managed.
Kartik?
So in that question, there was an issue about using a nerve graft or using a nerve transfer. So let me just make it clear. If you want to have a nerve grafting, then you need to have a proximal functioning axonal structure. So, in a certain time of my career where I already finished my training in plastic surgery, but yet did not do my neurosurgical training, I had the opportunity to take part in this kind of surgeries performed by my former teacher, Professor Shakat. She used to do a lot of vestibular schwannoma surgery. And in some instances, when she had a proximal stump at the brainstem level, she used to call me and say, just put a sural nerve there and then suture it to this nerve stump and let's see what happens. We also did some extracranial nerve transplants, nerve grafting. It never worked well. Not in one instance do I remember or recall that an extracranial grafting or intracranial grafting right from the brainstem worked well. And also because probably was what Corey showed, that the regeneration at the level of transection at that level is never going to work. And we didn't know this. We just saw the nerve as a structure. So that answers the question about nerve grafting. So if the nerve has been preserved 12 months ago, like in the scenario which had been presented in the question, there is no discussion about wanting to do a nerve grafting at all. So it has to be nerve transfer. So what nerve to use for nerve transfer, what axon donors we use to nerve transfer, again, depends on various choices. And of course, we start planning the surgery at 3 months, at least, to get the scheduling done before 6 months. Thank you.
Okay, so, well, I have to say I would actually, if I would be the surgeon with a vestibular schwannoma, and I know I have transected the nerve, and I have a donor and a recipient, I would go for nerve reconstruction anyway. First reason being, I have not had many cases, but I showed you one with a not so bad result, and I would just try. Because if it's not working, I still have the other choices.
Right.
And it will not take that long if you go for direct repair. I mean, the recovery period will not be that long. Okay, so we have the next cases, and thank you for the questions in Q&A. So very good.
Thomas, I'm the next case, or?
Yes.
So. Can you see it? Okay.
Yes, it's good.
So first, sorry, I had some technical problems. Congrats, Mette, on this excellent result. When you ask me now, I would say I would do everything like you did, because it was really a perfect result. So I will have a short talk on my strategies to the paralyzed eye. This elderly lady came to the outpatient clinic with some idiopathic facial palsy. Christina Repic, our speech therapist, already did an excellent job on her, but the eye was a little bit her problem, and she showed all the typical characteristics that you can find when you have facial paralysis on the eye, this lagophthalmos, also this lower lid ectropium, and she asked if we could help her out with her eye. So we set up the reconstructive targets, and we had 2 targets for surgery: the upper eyelid, because the upper eyelid paralysis leads to corneal dryness and to exposure to pain and can lead to ulceration, and also the lower eyelid paralysis, which causes epiphoria due to the poor tear drainage, but also causes some ectropium with corneal exposure again. So my targets were the upper lid and the lower lid. For the upper lid, as I told you in my presentation before, in most of the times we are using these upper eyelid platinum implants. In my experience, they work quite good. I don't have a big complication rate of them. The only thing that is not so easy for me is to estimate the right amount, because in many cases, the estimated amount of weight that I choose in the outpatient clinic, when you fix it on the outside skin, is a little bit too low. And my experience that intraoperatively you can take it a little bit higher, because the vector, when you fix it preoperatively in the outpatient clinic on the skin and intraoperatively in the correct plane, is a different. So I do just a simple platinum implant on the upper lid, which I use the supratarsal fold as a skin incision, and then create a suborbital pocket and position the implant over the tarsus. And then I fix it with some slow resorbable sutures, and that's it, and I close the pocket and the skin. For the lower lid, there are many techniques, and my preferred technique, because it's easy and it's quite reliable, is the lateral tarsal strip. So in shortly, I just make a cantotomy and shorten the lateral portion of the tarsus, so that we get from a scleral show with a lower lid ectropium to a good tension on the tarsus and correction of the scleral show. So you do that, you make just incision, and then you just clear up the tarsal plate from the conjunctival layer and the hair. And then you fix the tarsus in the appropriate amount of tension. you can fix it on the lateral dorsal ligament, but you can also fix it on the inner side of the lateral orbital rim, which I prefer because I prefer a higher vector. So these were the two things we did in this lady. These are the post-op results of the lady. I think the eye closure is quite good. She had no functional results. She did not use any bandage anymore, closed chamber or anything. And also I think the lower lid ectropium is corrected quite well without any scleral show. So thank you.
Thank you for this case, which shows that sometimes there are also quite effective, easier solutions, right? Any comments? Comments, questions? Mette, your hand is still on. Do you have a question, or is that?
Yes, I left it from the last time, but I have another question or a comment, or just how long post-operative were you? How long follow-up did you have on this lady?
On this lady, the latest pictures I think was 2 years post-operative. It's not post-operative, it's idiopathic, but post-operative for my last correction.
Yes, yes.
Because I saw the lady, I will see the lady because of some skin tumor excision, and I will take some pictures now. But I have quite, I think, a long follow-up of her.
Yes. Sometimes I experience that there's a tendency to recur. There's a tendency for the ectropion to recur when you have no muscular tone to the face. So if you have in the really elderly with really lax skin, there's it often recurs. And sometimes we then do take a fascial strip to make like a hammock underneath along the inferior palpebra. And this is usually less prone to recur. So
okay,
that was just a comment. Thank you.
Thank you.
Okay, so then we have next case presented by Christina.
Can I just say something, Thomas? When are we going to hear something from Kartik?
I
think
Kartik actually asked me to switch his case, which are actually a few cases in the end. That's why I skipped one number.
Okay, I will keep quiet.
No, you shouldn't.
So now I want to show you 4 different cases of multidisciplinary treatment with the focus on speech and language therapy. So the first patient is a 35-year-old female patient. She had a traumatic brain injury after a riding accident. She had a temporal bone fracture, including the pyramidal shape of both sides and several facial fractures. She got a craniotomy and a repositioning of fractures. And after the accident, she had a peripheral facial palsy. And the therapy, the accident was in April 2020. And the therapy started 10 days after the accident. So here is a picture from the patient during the hospital before she went to rehabilitation. So you see here she has a problem with eye closure. She has a complete peripheral facial palsy on the left side. And this is the picture, or these are the pictures after the rehabilitation and the cranioplasty in August 2020. So you see here there's still an incomplete peripheral facial palsy. She has a reduced facial expression, asymmetry in calm and during motion. She has a shifted philtrum and elapsed nasolabial fold, and she has problems with salivatorius, and the corner of the mouth is also drooping, and she had problems with drinking and eating. And she still has a hearing problem and a tinnitus. And the elements of speech and language therapy had been lymphatic drainage, scar massage, active exercises, tone activating techniques to support the muscle activity, and biofeedback training. And I also offered relaxing techniques because of the synkinesias. Here you see the patient 1 year after the accident. When you see in March, she is still asymmetric. She has a shifted philtrum to the right side, and the corner of the mouth is drooping. And 1 month, so in April 2021, after doing her exercises and focusing on the exercises again, she got more symmetric. And these are pictures from the accident in 2020. And on the right side, you can see a picture from the patient in April 2020. Here she is symmetric in calm. She has nearly symmetric eyebrows. The philtrum is also in the middle, and she's able to do facial movements. And the only problem she has is the synkinesia between the eye and the corner of the mouth. She has no drooling anymore of liquid. She's able to chew on the left side, and often she has the problem during chewing that the eye closes a little bit, but in the multidiscipline, as I introduced her to the plastic surgeon, to Mr. Neuwirth, and she got Botox. And now it's for her better because the eye stays open, and she often has a discomfort and a little bit of pain in the cheek area, and therefore she is still coming to therapy to me. So here is a short video. So you see that the area of the mouth works if she makes facial expressions or facial movements. And if she practices the eye closure a few times, she can close it fully. I'm sorry, I think the video is a little bit of slowly. So this is a patient where we didn't need any operation, but she got Botox. And another year you already know is the 24-year-old male patient. He had a vestibulare schwannoma, and he had post-surgery a mild dysphagia, a glossopharyngeal paresis because of the operation, and vertigo. This is the patient after the vestibularis operation, and he has a peripheral facial palsy on the right side. And we started with therapy a few days after the first operation, and then he went to rehabilitation. He had problems with chewing. She had often a liquid drooling and problems with eating and drinking on the right side. And he had an incomplete eye closure. So first he got to rehabilitation, but and he got accompanying speech and language therapy. But still 1 year after the first surgery, there was no improvement. So we decided that he will get this cross-face transplantation and the gracilis graft. So this is the patient before the operation. Dr. Neuwirth already showed you this. During the whole time, speech and language therapy was accompanying, and the aims of therapy had been the improvement of motoric conditions, the control of facial movements, the improvement of strength and endurance of the muscle. I tried to improve the function of chewing, swallowing, and drinking, and I offered relaxing techniques. And after the operation, after the Suralis transplantation, I offered techniques to improve the blood circulation and the lymphatic circulation. And after the gracilis transfer, I also used functional electric stimulation until the point when the nerve connected to the muscle and sprouted out into the muscle. And if he was able to activate the muscle, I stopped with functional electric stimulation. And here are some photos of the relaxing techniques. And now the patient is, the elements of the therapy after the surgery had been the understanding for the new mechanism, because it is important that the patient understands the new functions of the nerve. He got electric stimulation, relaxing techniques, active exercises, lymphatic drainage, and scar massage. And here you see a video where he was able to activate the muscles, I think 3 months after the gracilis transfer. So this is slide movement, but he needs good concentration to activate the muscle, and the muscle needs a clear order to move. And after few repetitions, the muscle tires, so he needs to make a break. Okay. So the physical issues after the 2-stage dynamic operation had been that the patient was able to control the muscle activity. The aim was to strengthen the muscle, and now I think the operation was very good, because now you see a slight natural facial movement during conservation, and smiling. And he has no problems with eating and drinking, and the symmetry is better. But also Dr. Neuwirth told you that he will make a mid-facelift. So another patient is a patient who had an idiopathic facial palsy. He is 50 years old, and she came to me 5 months after the onset of the disease. He is asymmetric at rest. He had a scleral jaw, a hanging eyebrow, a droopy corner of the mouth, and the elapsed nasolabial fold. And the facial palsy was about House-Brackmann scale 5. He wasn't able to move the muscles. He had problems with eating and drinking, and also during speaking the muscle tired, and he had problems to talk for a long time, and he had some tension and pain in the affected side. So the therapy start was nearly a half year after the onset of the therapy. And yes, the goals of therapy had been to improve the self-awareness. I tried to use techniques to support the earlier onset of the muscles, biofeedback skills like mirror training, and I also used relaxing techniques and tried to reduce the pain and discomfort on the left side. And here you see a picture of the patient, or a video where you can see that he has a few synchronicias. But he's quite happy that he didn't need an operation. And for the synchronicias, he got Botox. And he has also a complete eye closure now. So here you can see the picture of 2020, and here a picture of 2 years later in 2022. Here you can see that the patient is more symmetric, and he has facial movement. Do I have still time to do two further cases, or? I don't understand you.
I think not two other cases. We are quite over time. So if you just have a quick different case, just a picture, yes. Maybe.
One would be important. So this is a patient where we a temporalis transfer was made. He had a vestibularis schwannoma, and he had also problems, all the physical issues, and he got a titanium palate, and so it is essential that the speech and language therapist works with the patient to reduce the pain and discomfort. So here you see if the patient is chewing, he can lift up the corner of the mouth. So thank you for listening.
Well, thank you. Thank you very much. So I think we directly go on, and then in the end we can do a short Q&A. So next will be Copenhagen, and Kartik, as wished, is the last one, correct? So we have two cases from Copenhagen. Mette, you're still mute.
We are still here. We're still here. We will be with you. 2 seconds.
Så siger vi skærm.
So we will share the screen now.
Here we are. Here we are. So we had a young, a 26-year-old female who had a debut with right facial paralysis, spontaneous, after the following year. It improved until near normal. And then during the next following 2 years, she had a stepwise recurrent of the paralysis, ending with this House-Brackmann 5 to 6 at the time of referral. I will go straight on to say that we also did a cross-facial nerve graft in a 2-step operation, and subsequently a gracilis muscle. Just to add to the bulkiness, we actually also did a debulking from this over big gracilis graft that we did in the early days, and it actually resulted in a complete paralysis again for about a month, where I didn't sleep or speak or do anything. But luckily it came back, and she's now like this, considering only now after several more years to have some corrective eye surgery. She did not want this so far. And then during this time, a facial nerve schwannoma was found and operated also. I don't know if Kåre has any comments to this. He knows the patient as well.
Well, she had this diagnosed, but actually there was a very early MRI scan from 2009 where you could easily see the small facial schwannoma, and that is just to remind you that if you have a facial palsy and you do an MRI scan, you should look all the way through the course of the facial nerve, intracranially and in the skull base, to look for any tumors or any causes. So she's now running a case against the hospital to get some compensation, and she's likely to get that.
So that was it for us.
So there are no 2 cases from Copenhagen.
You want the next one? That's Kåre's case. Yeah, sorry.
Okay, I'll just show something different then. Let me just see. Do you see my screen now? Do you see my screen?
Not yet.
Not yet, okay. I think I probably have to go out and then come back. I'll just stop sharing the screen for a moment, and then I'll find the cases, and then I will come back. And now I will share again. Can you see it now?
Yes.
Okay. So
this is case number 1.
This was the first case, yes. I'm just going to go through this. And we are just going to skip case 2, as this was just a graft. And we'll go to case 3, which is this giant vestibular schwannoma patient, a young man of 26 years old. And he already had a facial palsy at the time of the surgery. And during the operation, we could not stimulate the facial nerve at any stage, not even when we got to it in the fallopian canal. So there was no ways of we could get control of the facial nerve. Just tried to preserve it, and we thought we preserved it. We left kind of a bit of tumor, and then we waited for 9 months. This was the 6 months post-op. We waited for 9 months, and then when there was no function at all, we decided to remove the whole tumor. We could not find the facial on the brainstem, and then we decided to, in the same procedure, to do a 12/7 anastomosis with a sural nerve graft. There are 2 ways you can do a 12/7. Either you can use the sural nerve graft without mobilizing the facial nerve from the fallopian canal and insert it into side in the hypoglossal nerve, or you can mobilize it from the fallopian canal and turn it down. And quite often you can get it to reach, but not always. So sometimes you still have to use a nerve graft. And this is a young man. This is 2 years after the anastomosis. And you see here the video. He is moving his tongue now, asked to move his tongue. So he's moving the left side of his face. Now he's relaxing. He's removing again. He's closing his eye now. Yes, you can see it's not quite, but when he moves his tongue at the same time, then he will close the eye. And at rest, he's actually quite symmetric, and this is what we regard as a reasonable result in this situation. He has no recurrence of his acoustic neuroma, and that was it from us. So thank you.
Well, thank you very much.
You can see the tongue is
impressive
not
case.
Okay.
If I might add, this is I think this is much more than reasonable. the result. Kartik is going to round it up with a potpourri.
First of all, I'm totally overwhelmed by the fantastic cases that have been presented today, and I would like to commend and also underline the importance of the work of the physiotherapists. And I find it extremely good that you included your physiotherapist in this meeting. So I'm just going to repeat whatever was said so far, and I'm just going to just a moment. I need some. I'm going to share my screen. I'm going to summarize whatever was had been said today. So I just want a short feedback that everybody could see my screen.
Yes, your screen is on.
Oh my God, where's? All right, so we will talk about an algorithm of facial reanimation. And thank you very much for putting this meeting together. And there are no conflicts of interest. The skeletal muscles affect volitional soft tissue movement. You know, in the face, actually, if you just take the silhouette, you just can't recognize if there is a facial palsy or not, because it is a movement of the soft tissue. It is not a movement of joints. So the mimic musculature are striped skeletal muscles, move soft tissue. They're volitionally controlled. The other soft tissue, other striped muscle that moves only soft tissue is the cardiac muscle. So this is very unique. The mimic musculature moves soft tissue, does not move joints, but it is yet volitionally controlled. So there are innumerable combinations of how contractions of several muscles. And if you can see a short sketch of Rowan Atkinson, within 30 seconds, he would show you a completely varied possibility of combining the mimic musculature. So we come to talk about the muscle and the nerve. So a normally innervated myocyte releases transmitters upon a command, upon an idea, a notion, and there is an actin-myosin gliding taking place to cause a contraction, and there is a learning process to control this type of contraction. So if there is a myocyte denervated, then there is no relay of the command, and there's loss of transmission, and slowly the synapses or the neuromuscular junctions start degenerating, which leads to atrophy of the myofibrils. And there's a long process of relearning after repair, and that is why the physiotherapy is very important. And there is some reversibility after repair within a certain time, but after that, if we miss that time, there is connective tissue transformation and fatty degeneration of the muscle tissue. So at that point, even if you reinnervate or stimulate, you're just going to stimulate a piece of cloth, not an active contracting muscle. So if we're talking about the time lapse, the denervation of the myocytes and reversibility after repairs till about 6 to 8 months for the nerve musculature, and for certain other muscles like the deltoid muscle, it's much quicker. So if you see a person with a circumflex axillary nerve lesion, the atrophy of the deltoid muscle happens very, very quickly within a couple of months, whereas in the face, it takes a little more time. So that is why the window of opportunity to re-innervate the muscle is quite protracted when it comes to the facial mimic musculature and the facial nerve. And after about a year, connective tissue transformation occurs, and there is a fatty degeneration of the muscles. So despite all these combinations, the area of surgical reanimation of the face focuses mainly on the eyelids and the oral commissure, as we had already seen in many of the cases today. So the classification of facial palsy can be upper motor neuron lesion from the facial homunculus on the M1 and M2 areas. It can be an acute lesion because of a stroke or some other lesion, and it can be of the lower motor lesion at the level of the brainstem. And it could, the question about these acute lesions are the necessity for reconstruction at that particular point. So if a person is having a stroke, and we are not even going to think about reanimating the face. So the general condition of the patient is important. And until the time the facial palsy becomes an issue, it's going to be quite late. Peripheral nerve lesion leads to hemifacial palsy, and there we can discuss about the different types of nerve reconstruction, either a direct suture in case of, for example, a traumatic injury, or sometimes dog bites or knife or stab injuries, or injury with glass shreds. And so on. And there are also possibilities of nerve transfer, which we have been discussing today. So irrespective of whether we perform a reconstruction or not, all these can become chronic lesions. So this is an example of a case where our max fac surgeons had a patient with a parotid tumor, and they had removed the tumor, and they had to sacrifice the facial nerve. However, they marked the ends of the facial nerve with 2-0 silk sutures, black silk sutures, and called me the next day and say, "Listen, we just had marked the nerve ends, whether you come and do the reconstruction." So this is a very straightforward case. So you just open up the wound and go in and find the marked nerve ends and put them together by means of sural nerve grafts. And this is a fantastic result. So the time when we do the reconstruction is quite short, and it has been done immediately, and it has been done in a sort of restitutio ad integrum fashion. So there we can actually await fantastic results like in this case. However, when the proximal end of the facial nerve could not be found or is not available, then we go ahead and do some kinds of nerve transfers and find axon donors. This can be hypoglossal nerve, it can be the descending branch of the hypoglossal nerve, or formerly it was called the ansa cervicalis, cervical, or the neck loop, ansa cervicalis, and now it's called as ramus descendens, the descending branch. And of course, you have several other types of nerve transfers. They always obviously lead to synkinesis. So our preferred method here is to use the descending branch and a jump transfer. So this is a clinical picture showing the facial nerve and the hypoglossal nerve. I just put this picture in order to show you the size adaptation of the hypoglossal and the facial nerve. And again, we also talked about split hypoglossal transfer. In my experience, this was never possible because the hypoglossal nerve is a monofascicular nerve, and it has a lot of axons inside, but it is one fascicular bundle, so you cannot separate the fascicles. It is actually an anomaly when you see a multifascicular hypoglossal nerve where you can really split nicely some fascicles and then take them out and then transfer it to the facial nerve. So in this case, we use the entire facial nerve not only by, for example, Susan McKinnon suggests the use of just the lower quadrant of the face to be reinnervated with this kind of method. And here you can see the result before and after. And since the suture line is relatively near to the target muscles, the reinnervation is quite quick, so we don't need to wait for too long. And you can see the reconstruction of the nasolabial fold, and there's even some kind of hypercorrection there. So the surgical morbidity with this kind of thing is the tongue atrophy because of the sacrifice of the hypoglossal nerve. And in order to overcome this, there are several techniques. One of them is naturally the use of a partial hypoglossal nerve, which I'm very skeptical about, But however, it has been published and has been shown in several series. So we just accept it without questioning. The thing which I really find interesting is to dissect both the descending branch and the hypoglossal nerve, and from that point onwards, see which size coaptation is there for the facial nerve. Sometimes it is the descending branch itself. Then you just transfer this descending branch. That is quite enough. But sometimes it is not appropriate. So we take the hypoglossal nerve for the facial nerve transfer. However, we take the descending branch and transfer it to the hypoglossal nerve, so that in order to prevent tongue atrophy, like in this case I showed you before. So there is the hypoglossal nerve, which has been transferred to the facial nerve, and the descending branch to the hypoglossal nerve. So now we come to a situation where the muscle has undergone connective tissue transformation, and there is fatty degeneration. And what to do? There are secondary reanimation procedures. We also saw quite a few of them today, and I will summarize them as local muscle transfers or free vascularized and innervated muscle transfer. So we have several options here: temporalis transfer, masseter transfer. In case of local muscle transfers, here's an example of a part of the masseter muscle which has been transferred to the lower part. I use this kind of procedures especially in the elderly patients where we don't want to deal with the microvascular structures. And this is another schematic representation how the temporalis muscle, the temporal muscle, is innervated by the trigeminal nerve. It's a temporal branch of the trigeminal nerve. So there's a complete different innervation pathway there. And there we use the same muscle for both the oral commissure reanimation and the eyelid reanimation. Of course, during this kind of surgery, you do a corrective face lifting as well. So you showed this picture already before. Quickly, I'm just going to take you through. Here you see the intraoperative picture of how the temporal muscle has been turned over to reanimate both the eyelid and the oral commissure in an elderly patient. This is the preoperative state and postoperative state, the upper row. However, the results are quite short-lived in this kind of, I just call it static transfer, because even though the muscle is innervated, it is not, in my experience, it doesn't really perform a movement of the oral commissure. So there are advantages and disadvantages of local muscle transfers. It is a simple procedure, it's quick and easy. It produces immediate results. However, it is not completely dynamic, as I told you, and the vector of movement is different, and it is not long lasting. It relapses after about a year. So sometimes we need to go in and do again a kind of facelifting and so on. So the free vascularized and innervated muscle transfer is a known option. It is not something new. And here I take you through again the steps of surgery. Figure A, where the gracilis has been marked, and a part of the gracilis has been harvested in figure B with the nerve and the vessels. And in figure C, this has been brought to the face, and the nerve has been it has been reversed and brought to the face. And the nerve has been transferred across the philtrum to the contralateral nasolabial fold, as you see in figure H. And in figure D, you see the facial vessels have been exposed, and there is a microvascular anastomosis between the vessels to the gracilis and the donor vessels, and you do the nerve coaptation or nerve transfer between the end branches of the buccal branches of the contralateral facial nerve to the facial to the nerve innervating the gracilis muscle, the split gracilis muscle. And the other option is to use the mesenteric nerve as an axon donor, as in this case. And here is a better illustration of it. This is the option which I would certainly prefer, because again, the suture line between the nerve to the gracilis and I say gracilis all the time, but you can use serratus anterior sometimes, or you can use latissimus, or you can use whatever muscle you want. Some people use muscles from the forearm. The plastic surgeons know it very well. And so the suture line between the motor nerve to the transplanted muscle and the axon donor is quite near to the muscle. So the results can be expected very quickly. One modification which I prefer in this kind of surgery is to suture both veins of the vena comitatus, both veins of the muscle flap. This is because it reduces postoperative edema and also lymph stasis. And this is a case which was operated by my former teacher, Professor Shakat, very many years ago, brainstem lesion, and we performed gracilis free muscle transfer to the right side of the face. Again, as I told you, I use the endoscopic technique in order to minimize, to create the buccal pocket where the muscle would be lodged in, and I usually reduce the bulk of the muscle before I transplant it, because once you transplant the muscle and to debulk it later, there is a high risk that you might denervate the muscle after debulking, and you might compromise a good result. However, you see what happens. This is the dynamic result of this patient, where the muscle is the commissure, the oral commissure, the excursion of the oral commissure is very nicely seen. But after about 6 years, you see the muscle has become very bulky, and there's a lot of hyperinnervation of this muscle. So there might be a necessity to go on and denervate the muscle, or even use Botox to partially denervate it by medical means. The downside of using the Botox is Botox as an antigen. So your body is going to develop antibodies against Botox, and after a couple of times of injection, it's not going to work anymore. So this is something which you have to keep in mind. So in this surgical algorithm, I would like to show that in a chronic lesion with a patient who is compliant, the questions we need to ask is, what is the goal? What is the age? What are the concomitant diseases? What is the vascular status? If these are not provided, then you go in for static procedures or simpler procedures like facelifting or suspension, tarsorrhaphy, canthopexy, lid loading, and so on. You'll also resort to some kind of semi-dynamic procedures such as temporalis transfer or suspension, masseter muscle transfer, or a combination of all these things. However, if the patient is compliant and young, and I would rather go in for a dynamic microsurgical procedure in a one-stage manner, using the free vascularized and innervated muscle flap with the axon donor as a contralateral facial nerve from the nasolabial fold. This is one option. The other option is a mesenteric nerve, which of course leads to a lot of synkinesis, which we have been discussing today in other presentations, and or the upper branch of the ipsilateral facial nerve or the hypoglossal nerve and other motor nerves. Thank you very much.
Okay, so Let's say thank you to everybody who has spoken today. It was great to hear from all of you, and I just want to, on behalf of your patients, to thank everybody who listened to this webinar, because it's your patients you're going to help. And of course, you should be able to do a direct suture and a nerve graft in the CP angle, but you should not be able to do everything that we have shown you today. You probably need a population base of 5 to 10 million people to have this kind of service, and you need a teamwork, and you need speech therapists, and you need the whole setup. So what you need to know is when to seek advice, when to seek help, and where to get it. So that is your task. And if you want to join the complex facial nerve team, then it's a great place to work. And we have a lot of enjoyment here in Copenhagen from working together and operating together. And so in the end, I think this is for our patients. Thank you for listening to this webinar. And I don't know if you want to say anything at the end, Thomas.
Well, nothing to add. I think we saw a lot of aspects have not only been touched but also explained. I hope the audience enjoyed it, and thank you to everybody.
Thank you. Bye bye. Have a nice evening.
Have a nice evening.